Hello, my name is Roy Sternin. I'm a guest student doing an open courseware course that is going to use as my final course in my master degree in health management. And I especially chose this course because we didn't have anything about rehabilitation in our curricula, and I was so interested in this subject due to my personal story with an illness called POTS syndrome. So, what is POTS syndrome? POTS is a disorder of the autonomic nervous system. So our body have two types of reactions in our nervous system. One of it is automatic, and one of it is something that we can control. So if these two branches are actually working fine, you will never even know it. But if they're not synchronized in the right way, you can have a series of uh, symptoms, and there are a few morbidities that are connected. Um, the name of this umbrella of illnesses is dysautonomia, and dysautonomia is a dysregulation of the autonomic branch of the nervous system, and I'm suffering from the main or the most prevalent illness of all, recently even connected to long COVID, which is postural orthostatic tachycardia syndrome. And the hallmark symptom of it is when changing position, it doesn't matter if it's lying down to standing up, being supine, or just a rapid change of position, like standing up from a chair, there is a maladaptation of the autonomic nervous system. The heart, blood vessels, breathing, and other mechanics are not working functionally, which lead to severe symptoms. Of course, this is just a hallmark sign that got this illness the name, but in general, this is a very debilitating illness. It used to be classified as a rare disease, but not any longer. Since COVID, we are estimating around 3 million patients around the world, even more. And I had the honor or mishonor to found the Israeli Society of Dysautonomia, and I'm acting also as a patient advocate in my line of work. So naturally, because this is so close to my heart, I chose a fictive case that is around POTS syndrome. I've created an avatar or a persona of Sarah. She's a 19-year-old. This image we're using here is AI generated to not use any picture of a real person or not violate any privacy laws. The reason I chose a female in her teen years is that the ratio between male and female in POTS syndrome is around 1 male to 8 females. The estimation is that because of autonomic nervous system failure that derive from autoimmunic response, since females naturally has more tendency for autoimmune illnesses. One of the assumptions is because the immune system of a female is stronger than a male due to her ability to bear children and protect them in the womb. So we have prevalence of all autoimmune system, which is much greater with females. We see it in lupus, in Crohn's disease, and so forth. POTS is not different than that. We have a lot of comorbidities, but the main onset stage is usually around teenage years. For me, it happens around the age of 18 and a half, 19. We see a lot of young teenagers, females arriving to emergency room after faintings, feeling shortness of breath, chest pain, dizziness, and so forth. And the evaluation that is being done in the last few years, talking about around 6 years to diagnosis from the first onset of symptoms. This is something that I'm fighting for vigorously in my country, and we've managed to lower this period of time due to awareness raising among medical professionals, creating a diagnosis pipeline, and other means. So our Sarah, she's attending college. and she feels so bad that she feels that she cannot participate in her studies on a regular basis. Um, she is struggling with anything that is autonomic regarding position changing, as we mentioned before, but not also. She's suffering from malaise, severe weakness. She's suffering also from fainting, sometimes on a daily basis, something that it puts her safety at risk. Our Sarah is also experiencing severe brain fog, which is very common in POTS, which makes life as a student very hard. I suffer from it often. This is one of the reasons it was hard for me also to complete this task, but I learned to navigate my life and live with it. And sometimes she has to miss school due to her condition, and I'm trying to find a way to help Sarah um, to live a better quality of life. The selected intervention that I chose is based on a program that we used to call as a nickname the Dallas program, because it was developed firstly in the Presbyterian Hospital in Dallas, Texas, the United States, and it's a physical rehabilitation program, which is a personalized recombinant exercise, which is based on sitting down exercise, which is not reaching the level of the severe exercise intolerance that people with POTS have, and it's a gradual program. So the program is based on a scale, um, and scale that is based on level of intensity, and after an evaluation with a heart physiologist and rehabilitation expert, usually this program is being even more personalized. So because Sarah is still not bedridden like I was for many years, I actually spent more than 7 years in bed due to misdiagnosis and deconditioning. Sarah is still able to attend some social activities and some studies activities, so she's actually in a very good position to start with, and she doesn't need to start from the point of lying down and working on muscle strengthening. She can sit up and do it. This rehabilitation program is heavily based on sit-up bicycle training, and after a short period of a few weeks, um, when the muscles in the legs are being strengthened a bit and the return of blood, the venous blood, to the heart is improving, then we can increase the levels. We have wonderful results using this program, and in Israel we work with the National Center for Dysautonomia that we helped found in the Shiva Medical Center in Tel Aviv, and this is the gold standard that we are using. The problem, and it's a huge problem, is that Israel, as small as country as it is, still is a very narrow and long country, which means that some people are a few hundred kilometers far away from this central hospital. And despite our great effort to insert this training using personal trainers and physiotherapists into the HMO system in Israel, we still have a lot of rejections regarding the deployment of it, especially with the reimbursement of the insurance schemes. And we were not able to make it into primary care, and we're completely dependent of secondary and tertiary care. Sometimes people have to be admitted for this program, and others have to attend 3 times or so a week this major hospital, and it's very hard for them, especially in hot days, because of vasodilatation and excessive heat intolerance and fainting, to attend. So my idea was to create a safe remote monitoring um, in order to intervene, which is based on a basic mobile digital health app and connected to a wearable tracker. This wearable tracker doesn't have to be something as expensive as a Galaxy Watch or, of course, an Apple Watch. It can be a very basic one that can be costume ordered by the tech company who will deploy this app, or by the medical center who will deploy this app or use it, which is a very simple but accurate heart monitor that checks basically heart rate, heart rate variability. It doesn't have to evaluate the blood pressure itself. It's enough to just check those parameters and provide feedback. And during the safe stage, because we have stages of fainting, which is not so safe to train at home, but providing a patient with a mini sitting down bicycle that costs something around 30 euros. I have one of those, 30 to 50 euros, and this tracker, using this app, we can create a situation in which we are getting even better results in terms of rehabilitation and conditioning, because, in my opinion, of course, there is a huge effect of going into a place to do something that is good for you. But on the other hand, it's very hard for the rehabilitation team to monitor in the same time, since we are doing this rehabilitation in the same room with the cardiac rehabilitation people. So we have a social problem, because most of the people are above 60 or 70 with those very young patients, and you have just a few physiotherapists taking care of 50 people or so. I believe that when applying a solution like this, we might see a situation in which we adapt the hardship or the level of intensity and resistance to the parameters that are being received by the wearable into what's called patient experience data and patient-reported outcome. And with a very swift and simple algorithmic analysis, we can adapt this program. So we can actually make a program that is cost a few thousand euros to the HMO or the insurer into something that is costing maybe 100 to 200 euros to deploy. Of course, can be also combined with a periodic talk with the rehabilitation expert, but it also can be done remotely. And this is something that I've been thinking lately to implement in Israel, in my community at least. It was very important for me that to add something about patient empowerment. I think that this case really amplifies how patients are best positioned to be stewardess or champions of their own health. And with the use of data coming from the patient and coming back to them by the technology and personalized, we can really take care of something that I see as one of the pillars of recovery and rehabilitation, which is the sense of purpose and progression. And when you have it monitored using wearables and an app, and this app is some sort of a companion app for rehabilitation, we can optimize the intervention, and the patient is taking an active role in the condition management. I wrote a book about it, and in my book I'm using approaches coming from logotherapy by Viktor Frankl, which basically say that you're using methods of bringing back the responsibility into the person or into the patient or back to the patient, and using self-management tools and technology together, we can maybe achieve better recovery rate and improve health outcome. To summarize, for our Sarah, this individualized recombinant exercise was optimized and effective to improve her cardiovascular conditioning and functioning within her limitations. This technology helped enhance her personalized motivational and accessibility needs. And in my use case, and based on the recent data, Sarah could go back to quite regular attendance and participation in her studies within around 6 to 9 weeks. And this is something that is completely realistic in this case study. To conclude, I have a lot of knowledge that I've accumulated over the years about my own condition and about the needs of other patients due to the community work and advocacy that I'm doing. I truly believe that we have an health equity problem when it comes to fatigue-based illnesses, what I call them. Fatigue-based illnesses is just because of one of their hallmark features, but illnesses that are basically being considered orphan, invisible, have a lot of psychological effects as well. We're talking about illnesses like endometriosis. We're talking about illness like ME/CFS. We're talking about um, illnesses like fibromyalgia, like POTS, like long COVID. We have a huge psychological effect, and I would urge to incorporate in any rehabilitation program the mental aspect. We, in our community, working with the Shib Medical Center in Tel Aviv, we incorporate a dietitian, medical psychologist, a physiologist, and the physical rehabilitation team. I think that combining all of them will give a better potential to improve people's life. And after COVID, we have a breaking down of a taboo over mental health. But on the other hand, we are also seeing a little bit of cracks in the system that is sometimes very, very resistant to change. And we're seeing more and more remote solutions with remote monitoring, home admissions, and so forth. And sensory rehabilitation is a field that is usually highly dependent on patient participation and responsibility taken. I think that it's a great way to start with the overwhelming amount of people who are requiring this rehabilitation. We are seeing probably a few millions of people with long COVID that will need also physical rehabilitation. And solutions like that can simply save disability days, save money to the system, improve health accessibility and equity, um, treat disparities with different types of population that have less advantageous and gender-based medicine and other biases, and eventually will or might improve health outcomes. I, for this work, quoted as requested 10 articles and studies. I allowed myself to use also one of my books here that is engaging heavily in these matters. I hope that you had a nice time listening to my presentation, and thank you so much for the course team for the opportunity to delve deeper into something that I had to do by myself when I was sick. I taught myself basically how to walk and talk when I was 27 because I didn't have any healthcare professional who believed me when I was so sick. And I'm on a mission to improve others people's life, and I would be more than delighted to cooperate in any way. Thank you so much for this fascinating course and opportunity, and I wish you all the best. Goodbye.